Hello, and welcome to this AstraZeneca presentation, Reframing Rescue Therapy to Help Prevent Asthma Exacerbations. My name is Dr. Autumn Burnette, and I have been practicing medicine as an allergist in the asthma space for about 15 years. Thank you for joining us today. Please note this presentation does not qualify for any form of continuing education credit. The objectives for this presentation include the following. Recognize the impact of asthma exacerbations on the burden of disease for patients with asthma in the United States. Gain an understanding of the role of variable airway inflammation in the occurrence of asthma exacerbations and the consequent burden of systemic corticosteroid exposures. Appreciate patient preferences for immediate symptom relief and fewer asthma attacks. Review recent recommendations from the Global Initiative for Asthma, or GINA, and the National Asthma Education and Prevention Program, or NAEPP. And finally, examine data on a rescue therapy treatment option. When it comes to the science of asthma in the United States over the last few decades, how do you think we're doing? Well, let's look. The prevalence of asthma in the United States continues to increase, as you see represented here along the gray arrow. The latest CDC data from 2021 estimated that approximately 25 million people had asthma. From 2000 until now, several new therapies have been approved by the FDA for asthma. Fixed-dose combination inhaled corticosteroids plus long-acting beta-2 agonist inhalers, an anti-IgE monoclonal antibody, long-acting muscarinic antagonist inhalers, monoclonal antibodies inhibiting interleukin-5 or interleukin-5 receptors, a monoclonal antibody inhibiting IL-4 and IL-13 receptors, a fixed-dose combination ICS-LABA/LAMA, a thymic strongyl lymphopoietin antagonist, and most recently, a fixed-dose combination short-acting beta-2 agonist plus inhaled corticosteroid inhaler. So we clearly see that major scientific discoveries have been made surrounding asthma. And these type of discoveries have generated multiple updates by GINA and the NAEPP, as shown here going back to 1991, yet the burden of asthma persists. It is puzzling that severe exacerbations still contribute to asthma morbidity, including hospitalizations, emergency department visits, and use of corticosteroids, despite numerous advancements for the treatment of asthma. To fully appreciate the burden of a severe exacerbation, it is important to define severe exacerbation, which is a clinical deterioration of asthma with a worsening or a new onset of symptoms leading to at least one of the following events: treatment with or an increase in systemic corticosteroid in association with a healthcare provider encounter, an ED or urgent care visit resulting in systemic corticosteroid treatment, hospitalizations with systemic corticosteroid use or intensive care unit admission or intubation, and finally, death. Now let's examine the impact of severe exacerbations in the United States. A retrospective study, which evaluated claims data from 2012 to 2017 of over 435,000 patients 12 years of age with persistent asthma, identified that nearly 2/3 of these patients received oral corticosteroids during a follow-up period. For patients with asthma, data from the CDC in 2020 showed an estimated 990,000 annual emergency department visits and approximately 95,000 annual hospitalizations due to asthma. Moreover, in 2021, approximately 9.8 million attacks were reported by patients in the United States with asthma. To help address this burden, NAEPP and GINA support a shift in the rescue paradigm. As an allergist, I always feel it's important to go back to the fundamentals of airway inflammation to explain how it contributes to symptoms. Airway inflammation is central to asthma symptoms and exacerbations. In patients with asthma, we can see tightened airway smooth muscles, airway wall swelling, infiltration with inflammatory cells, mucus gland hypersecretion, and a thickened subepithelial basement membrane with fibrosis. These changes can result in airway luminal narrowing and asthma symptoms. And importantly, the inflammation and symptoms of asthma vary over time and intensity and can lead to asthma exacerbations. Let's take a deeper look into how key asthma therapies affect the airway and help address asthma symptoms and inflammation. This slide helps to illustrate how short-acting beta-2 agonists, or SABAs, treat symptoms through bronchodilation, while inhaled corticosteroids address underlying inflammation and enhance the effects of SABA. SABAs bind to beta-2 adrenergic receptors on airway smooth muscle cells, producing airway smooth muscle relaxation. On the other hand, inhaled corticosteroids are known to reduce airway inflammation and augment bronchodilation through mechanisms that include both late-phase genomic and early-onset non-genomic effects. We often think of inhaled corticosteroids as having a delayed onset due to genomic effects, which include the activation of glucocorticoid receptor to alter gene transcription through direct DNA binding or modification of transcription factor activity. These late effects, which have an onset of 4 to 24 hours, include the following: increased anti-inflammatory gene transcription, decreased pro-inflammatory gene transcription, and increased beta-2 receptor gene transcription. However, inhaled corticosteroids have also been shown to exhibit non-genomic effects, which are characterized by a rapid onset that occurs within minutes, as well as a short duration of action. Such early onset effects include the following: amplification of beta-2 agonist-induced bronchodilation, decreased bronchial vascular blood flow due to the direct effect of increased norepinephrine, and suppressed immune mediators. When ICS is used as a part of an asthma maintenance therapy regimen, we rely on maintenance to help keep inflammation in check. However, as we discussed earlier, inflammation and symptoms vary over time and in intensity and can lead to an exacerbation. Let's explore this concept further. Patients with asthma experience episodic exposures to allergic and non-allergic triggers that can lead to variability in inflammation and symptoms. Treatment with an anti-inflammatory maintenance therapy is intended to address baseline levels of inflammation, as shown by the dashed line in the illustration. However, maintenance therapy may not always be able to address changes in inflammation. Rising inflammation may cause airway narrowing, decreased lung function, and increased symptoms, and can lead to an exacerbation. Increasing symptoms prior to an exacerbation may lead patients to increase their use of rescue medication. Here on the left, we present a figure from the FACAAI study, an exacerbation reduction study in response to inhaled corticosteroids with or without a LABA. This work examined the pattern of peak expiratory flow decline, symptoms, and rescue beta-2 agonist use in the 425 exacerbations that occurred during the study. You can see that peak flow fell while symptoms and rescue use increased in the 10 days before the exacerbation was diagnosed, and they returned to pre-exacerbation or near pre-exacerbation levels over the subsequent 2 weeks. As asthma symptoms worsen prior to an exacerbation, patients increase use of their fast-acting bronchodilators. Use of an as-needed fast-acting bronchodilator without inhaled corticosteroid to treat symptoms does not address underlying rising airway inflammation, thus further worsening symptoms, and the need for rescue bronchodilators can occur. Rising inflammation can result in decreasing lung function, as well as increasing symptoms and rescue therapy. This concept was further explored in a medical and pharmacy claims real-world study. Meredith market scan administrative claims data from 2010 to 2017 identified over 300,000 patients aged 4 years and older with moderate to severe asthma as defined by fills of GINA step 3 through 5 maintenance therapies. The graph on the right provides data from the subgroup of over 37,000 patients greater than or equal to 12 years old that experienced a serious exacerbation during the study, and showed that an escalation in both SAVA and maintenance fills occurred in the days leading to serious exacerbation, and that greater than 40% of patients did not have a maintenance medication fill within the month prior to a serious exacerbation. It is important to note that serious exacerbations in this analysis were a subset of severe exacerbations that were accompanied by an in-person, face-to-face healthcare provider encounter in an outpatient clinic, urgent care or ER visit, or hospitalization. These studies provide support that a window of opportunity may exist to help prevent an exacerbation if symptoms and inflammation are treated concomitantly. The INSPIRE study from 2006 identified patterns of rescue and maintenance use and examined patient attitudes towards asthma management. This study examined the attitudes and actions of 3,415 patients in 11 countries, including the United States, aged 16 years of age and older, with physician-confirmed asthma, who were prescribed regular maintenance therapy with ICS or ICS and LAMA. Structured interviews were conducted to assess medication use, asthma control, and patients' ability to recognize and self-manage worsening asthma. In this study, 38% of patients believed that there was no need to take medication every day, while 90% wanted immediate relief when symptoms occurred. Although most patients recognized the early signs of worsening, the most common response was to increase short-acting beta-2 agonist use. As we know, worsening symptoms can progress into an exacerbation, which may lead to systemic corticosteroid therapy. While treatment of exacerbations with systemic corticosteroid is often necessary and effective, observational data has suggested that standard bursts of systemic corticosteroids may result in a cumulative steroid burden impacting future health. Shown here is data from an observational study by Price and others demonstrating the potential risks of developing adverse health conditions due to varying levels of cumulative systemic corticosteroid exposure. The risk of developing conditions such as diabetes, anxiety, and depression as a result of systemic corticosteroid use increased as exposure to systemic corticosteroid accumulated over a lifetime. Shown here, statistical significance was evident when cumulative lifetime systemic corticosteroid exposure reached a threshold of 500 milligrams to under 1,000 milligrams. A greater risk occurred and more adverse conditions emerged, such as osteoporosis and cardiovascular disease, between the 1,000 milligram and less than 2,500 milligram of cumulative systemic corticosteroid exposure. In a separate retrospective cohort study and self-control case series, it was observed that within 30 days of oral corticosteroid initiation, the incidence of adverse events such as sepsis, venous thromboembolism, and fracture approximately doubled. Thus, treatment with exacerbations with systemic corticosteroids contributes to the burden of disease that may affect future health. You might be wondering, how easily can you reach the 500 or 1,000 milligram levels in a clinical practice? Based on recommendations from GINA and the NAEPP Expert Panel Report 3 from 2007, where a range of systemic corticosteroid dosing options are provided, even with one burst, a patient could be exposed to or even exceed that 500 milligram threshold, as shown starting with the yellow in the bottom right of the first column. With a second burst, many patients would reach exposure levels of at least 500 milligrams, with some even reaching at least 1,000 milligrams as shown in the red at the bottom right of the second column. And with a third burst, most patients would have reached a cumulative threshold where their risk for chronic adverse health conditions is significantly increased. Keep in mind, this is illustrative of the use of systemic corticosteroid for asthma and does not include other cumulative exposures patients may receive for the treatment of other conditions. In real-world use, it can be quite difficult for clinicians to track cumulative lifetime systemic exposures, as electronic medical records are often incomplete. Treating symptoms and inflammation concomitantly with rescue or reliever therapy that includes both an ICS plus a fast-acting bronchodilator is supported by the latest recommendations from GINA and NAEPP. As a reminder, SABAs and formoterol are considered fast-acting bronchodilators. In fact, NAEPP guidance from 2020 incorporates this concept at steps 2, 3, and 4 as preferred therapy, with concomitant as-needed SABA plus ICS, a recommended option at step 2, and ICS formoterol maintenance and rescue at steps 3 and 4. GINA also supports this approach with ICS formoterol as the preferred reliever across all treatment steps in track 1. In GINA, SABA-only treatment of asthma is no longer recommended. Also, GINA states the risk of severe exacerbations and mortality increases incrementally with higher SABA use independent of the treatment step. It is important to remember that the use of ICS formoterol is not approved in the United States for maintenance and rescue therapy or for as-needed rescue only. The recommendations for ICS formoterol are based on clinical data evaluating the use of ICS formoterol formulations and strengths not approved and not available in the United States. GINA includes recommendations for the concomitant use of SABA and ICS in its track 2 controller and reliever treatment steps for patients of all disease severities. As can be seen, the reliever options recommended in this track are as-needed ICS SABA or as-needed SABA. GINA also states that before considering a regimen with SABA reliever, check if the patient is likely to adhere to daily controller treatment. GINA emphasizes the importance of a personalized asthma management plan involving a continual cycle of assessment, adjustment of treatment, and review. The plan should be developed according to an individual patient's needs in order to achieve the goals of asthma treatment. If we treat symptoms with ICS-based rescue on top of maintenance therapy, will that lead to excessive ICS exposure? This question was evaluated in a real-world claim study, which assessed estimated daily ICS exposure if ICS was included with each use of SABA, relative to the maximum FDA-approved daily ICS doses for each NAEPP step of ICS therapy. Using the Meritive market scan databases, administrative claims for United States patients with commercial Medicaid and Medicare coverage, more than 500,000 patients aged 12 and older were identified between 2010 and 2017. These patients had 12 months or more of continuous benefit enrollment before and after a SABA index fill date and no evidence of any non-asthma chronic conditions commonly treated with systemic corticosteroids. All doses of ICS were expressed in micrograms of fluticasone propionate equivalents, with 50 micrograms of fluticasone propionate equivalent to 80 micrograms of budesonide. Patients were categorized according to the most common maintenance medication filled during the 12 months post-index period. Shown in the maroon shaded ovals above the bars are the maximum FDA-approved daily ICS doses in micrograms of fluticasone propionate equivalents, with hydrofluoroalkane preparations in the lighter color and dry powder inhalers in the darker maroon. Below, the yellow-colored portion of each bar represents the observed daily ICS exposure for each maintenance therapy as measured by the proportion of days covered. The dark blue portion of each bar represents the projected additional daily ICS exposure if a dose of ICS was added every time a SABA was used. As illustrated with each maintenance therapy, the mean estimated daily ICS exposure did not exceed the respective maximum FDA-approved levels based on usage patterns for ICS and SABA. The total estimated ICS exposure for maintenance plus as-needed ICS would range from 36% of the respective FDA maximum approved dose in the high-dose ICS LABA group to 100% in the low-dose ICS group. This study also evaluated systemic corticosteroid exposure based on claims data and compared it to the annual total estimated ICS exposures in milligrams. The table shows us that the annual mean systemic corticosteroid exposure was greater than the estimated exposures from ICS. As you can see in the top row, the annual estimated mean ICS exposure ranged from 22 milligrams in the SABA-only group to 148 milligrams in the ICS LABA-LAMA group. In the second row, you can see that approximately 32 to 56% of patients receive systemic corticosteroid treatment across treatment groups. The third row indicates that for all patients receiving maintenance therapy who had systemic corticosteroid exposures, the mean annual observed systemic corticosteroid exposure was greater than 500 milligrams, exceeding the threshold we discussed earlier, which has been associated with an increased risk of adverse health conditions. For those patients in the SABA-only group, the mean annual observed systemic corticosteroid exposure was 451 milligrams per year. When the two annual exposures were compared, the observed systemic corticosteroid exposure relative to the estimated inhaled corticosteroid exposure was at least 6-fold higher in groups receiving maintenance therapy. And for those on SABA-only therapy, it was 21-fold higher. Now the puzzle of asthma burden is starting to come together. Let's recap the pieces we've discussed so far. We know that inflammation and triggers vary and that maintenance therapy may not fully address these fluctuations. In addition, exacerbations persist even with the use of maintenance therapy. We've shown how guidelines and expert opinion recommendations are updated as the science evolves, and that the expanded management and treatment options require broad education and implementation. Thus, the question remains, can the puzzle be solved? We will now transition to a review of clinical data for AirSupra, a fixed-dose combination medication where each inhalation consists of 90 micrograms of albuterol and 80 micrograms of budesonide. AirSupra is a therapy that was designed to shift the treatment paradigm and help address the problem of exacerbations for patients with asthma. Please see the full prescribing information, including patient information for AirSupra, available at www.airsupra.com or at www.azpicentral.com. AirSupra was approved by the FDA in January of 2023, and it is a combination of albuterol, a short-acting beta-2 adrenergic agonist, and budesonide, an inhaled corticosteroid. AirSupra is indicated for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma 18 years of age or older. The recommended dose of AirSupra is 180 micrograms of albuterol and 160 micrograms of budesonide, administered as 2 inhalations of AirSupra, albuterol/budesonide 90/80 micrograms. Patients are instructed not to exceed more than 6 doses or 12 inhalations in a 24-hour period. Before reviewing the clinical data, let's focus on some select important safety information. Contraindications to using AirSupra include hypersensitivity to albuterol, budesonide, or any of the excipients. Deterioration of asthma can occur acutely or chronically, so if a patient continues to experience symptoms after using AirSupra or requires more doses of AirSupra than usual, it may be a marker of asthma destabilization. AirSupra can produce paradoxical bronchospasm, which may be life-threatening. If paradoxical bronchospasm occurs, air super should be discontinued immediately. An alternative therapy instituted. When associated with inhaled formulation, it frequently occurs with the first use of a new canister. Air super, like other drugs containing beta-2 adrenergic agonists, can produce clinically significant cardiovascular effects in some patients and may need to be discontinued. Air super should be used in caution in patients with cardiovascular disorders, especially coronary insufficiency, cardiac arrhythmias, and hypertension. Please see additional safety information and the full prescribing information, including patient information, at the end of this presentation. Let's now review key air super data from the Mandala study, a pivotal phase 3 clinical trial used to support the approval of as-needed therapy with a combination of albuterol and budesonide. The Mandala study was designed to evaluate the efficacy and safety of albuterol in combination with budesonide given as needed, albuterol/budesonide 180 over 160 micrograms or 180 over 80 micrograms, with each dose consisting of 2 actuations of 90 over 80 micrograms or 90 over 40 micrograms respectively, versus as needed albuterol 180 micrograms each dose consisting of 2 actuations of 90 micrograms as rescue therapy in patients with uncontrolled moderate to severe asthma. This event-driven study enrolled symptomatic patients who had experienced at least one severe asthma exacerbation in the previous year and were receiving maintenance therapy to treat moderate to severe asthma, as defined by GINA for greater than or equal to 3 months prior to the study entry. Randomized patients continued their background maintenance therapy throughout the trial. It is important to note that while patients 12 to 17 years of age were included in Mandala, air super is not approved in this age group. Therefore, efficacy results are only presented for adults 18 years of age or older. Since albuterol budesonide 180 over 80 micrograms is not an approved dose, this presentation will not include results for this arm of the study. In addition, select inclusion criteria for the Mandala trial were as follows: a physician diagnosis of asthma documented for at least 1 year, receiving one of the following scheduled asthma maintenance therapies for greater than or equal to 3 months with stable dosing for 4 or more weeks prior to screening, including medium to high dose ICS or low to high dose combination ICS LABA with or without an additional controller. Options included a leukotriene receptor antagonist, a long-acting muscarinic antagonist, or a xanthine. Pre-bronchodilator FEV1 of greater than or equal to 40 to less than 90% predicted normal, and confirmed reversibility to albuterol will also inclusion criteria, along with an AC-Q5 score greater than or equal to 1.5 at visit 2, indicating uncontrolled asthma. Select exclusion criteria included chronic obstructive pulmonary disease or other significant lung disease, systemic corticosteroid use within 6 weeks prior to screening, chronic oral corticosteroid use greater than or equal to 3 weeks of use within 3 months prior to screening, and biologic treatment within 3 months or 5 half-lives of screening. As you can see in the adult efficacy population, 2,940 patients total, baseline demographics were similar between the albuterol budesonide 180/160 microgram and albuterol treatment groups. Overall, the mean age was 52 years, and of the patients included, 66% were female, 82% were white, and 25% were of Hispanic or Latino ethnicity. Baseline disease characteristics were also compared across treatment arms. Overall, the mean pre-bronchodilator forced expiratory volume in 1 second was approximately 63% of predicted normal, with a mean reversibility of about 28%. With respect to the ICS maintenance-based therapies, approximately 30% of patients were receiving low-dose ICS LABA or medium dose ICS, 40% were receiving medium dose ICS LAVA or high dose ICS, and 28% were receiving high dose ICS LAVA. About 80% of patients had one exacerbation in the 12 months prior to screening, whereas about 20% had more than one severe exacerbation. Additionally, the mean ACQ-5 score was 2.6, indicative of uncontrolled asthma, and the mean AQ-LQ-12 score was 4.6 across treatment groups. Now turning to key efficacy results of the Mandala study for the participants who were 18 years of age and older. The primary endpoint was the time to first severe asthma exacerbation, with severe exacerbation defined as an asthma clinical worsening leading to one of the following: 3-day course of systemic corticosteroids or corresponding single injectable dose, an emergency room or urgent care visit due to asthma that required systemic corticosteroids, or a hospitalization for at least 24 hours due to asthma. Note the divergence between the albuterol budesonide 180 over 160 micrograms and albuterol arms on the Kaplan-Meier curve shown here. The data shown are for patients 18 years of age and older from the pre-planned on-treatment efficacy analysis, collected while patients were on randomized treatment prior to the treatment discontinuation or change in maintenance therapy. Data was censored at the time of discontinuation or change in therapy. Albuterol budesonide 180 over 160 micrograms significantly reduced the risk of severe asthma exacerbations in a time to first severe exacerbation analysis by 28% compared to albuterol 180 micrograms, with a hazard ratio of 0.72 and a 95% confidence interval of 0.6 to 0.86, and with a statistically significant p-value of less than 0.001. There were also significant results in the key secondary endpoints of the study. The annualized severe exacerbation rate was reduced by 24% for those receiving albuterol budesonide 180 over 160 micrograms compared to albuterol. The rate ratio was 0.76 with a 95% confidence interval of 0.62 to 0.93 and a statistically significant p-value of 0.008. Additionally, for patients treated with albuterol budesonide 180 over 160 microgram, the annualized total systemic corticosteroid dose when compared with albuterol was statistically significantly different, with a p-value of 0.001, with a 32% reduction in mean annualized dose per patient. Now that we have reviewed efficacy results, let's look at safety. Here we see a summary of adverse reactions reported in greater than or equal to 1% of the study population 12 years of age and older. For albuterol budesonide 180 over 160 micrograms, the incidence of headache was 4.3%, oral candidiasis was 1.3%, and cough was 1% compared to 4.9%, 0.5%, and 1.1% for albuterol, respectively. The safety profile of albuterol budesonide was similar to albuterol, irrespective of background inhaled corticosteroid dose. Just a reminder that safety data shown are for patients 12 years of age and older. AirSupra is not approved for patients 12 to 17 years of age. To complete the description of AirSupra, the next 3 slides provide additional important safety information. Patients should not exceed the recommended dose. Clinically significant cardiovascular effects and fatalities have been reported in association with excess use of inhaled sympathomimetic drugs. Hypersensitivity reactions, including anaphylaxis, can occur after administration of albuterol sulfate and budesonide, components of AirSupra. Discontinue AirSupra if the reactions shown on the slide occur. AirSupra should be used with caution in patients with certain coexisting conditions such as convulsive disorders, hyperthyroidism, or diabetes mellitus, and in patients who are unusually responsive to sympathomimetic amines. Significant hypokalemia may occur in some patients from use of beta-adrenergic agonists, and possible immunosuppression and potential worsening of infections from the use of inhaled corticosteroids could occur. Use with caution. A more serious or fatal course of chickenpox or measles can occur in susceptible patients. Additional important safety information includes oropharyngeal candidiasis has occurred in patients treated with ICS agents. Advise patients to rinse their mouth with water if available. Hypercorticism and adrenal suppression may occur with very high doses in susceptible individuals. Reduction in bone mineral density has been observed in glaucoma, and cataracts have been reported with long-term administration of inhaled corticosteroids. Orally inhaled corticosteroids, including budesonide, may cause a reduction in growth velocity when administered to pediatric patients. However, note the safety and effectiveness of AirSuper have not been established in pediatric patients, and AirSuper is not indicated for use in this population. The most common adverse reactions reported for AirSuper with an incidence of greater than or equal to 1% were headache, oral candidiasis, cough, and dysphonia. AirSuper should be administered with caution to patients being treated with strong cytochrome P450/3A4 inhibitors, short-acting bronchodilators, beta blockers, diuretics, or non-potassium sparing diuretics, digoxin, monoamine oxidase inhibitors, or tricyclic antidepressants. Use AirSuper with caution in patients with hepatic impairment, as budesonide systemic exposure may increase. Monitor patients with hepatic disease. Please see the full prescribing information, including patient information for AirSuper, available at www.airsuper.com or at www.azpicentral.com. To wrap up this review of clinical data for AirSuper, I would like to briefly summarize the key takeaways that we covered. AirSuper is the first and only rescue medication approved in the United States for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma 18 years of age and older. In the Mandala trial, AirSuper significantly reduced the risk of severe exacerbations by 28%, and the annualized rate of severe exacerbations by 24% compared to albuterol. In Mandala, there was a significant difference in the annualized total systemic corticosteroid dose with AirSuper versus albuterol, with a 32% reduction in mean annualized dose per patient. Most common adverse reactions with AirSuper are headache, oral candidiasis, cough, and dysphonia. When looking to reframe rescue therapy to help prevent asthma exacerbations, consider AirSuper, a rescue treatment designed to address asthma symptoms and airway inflammation concomitantly. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have any comments about this presentation, please contact AstraZeneca at 1-800-236-9933. For medical information requests and access to other AstraZeneca resources, please visit azmedical.com. You are encouraged to report negative side effects of AstraZeneca prescription drugs by calling 800-236-9933. If you prefer to report these to the FDA, call 1-800-FDA-1088. Thank you for your time and attention. This concludes this program. The references included in this presentation are available here and on the next 3 slides for your review.